Yep. Hello, and welcome to a very special podcast that is part of a series I'm leading on diversity and inclusivity with CME Outfitters. Today's CMEO briefcase is entitled Addressing Maternal Health Disparities, Changes You Can Make to Your Practice. I'm Dr. Monica Peak, and I'm a professor of medicine and associate director of the Chicago Center for Diabetes Translation Research here at the University of Chicago. I'd now like to welcome Dr. Hedwige St. Louis, an associate professor and assistant clerkship director in the Department of OBGYN at Morehouse School of Medicine in Atlanta, Georgia. Dr. St. Louis, I'm honored to have you and joining us today, and I'm excited about the discussion ahead.
Thank you so much, Dr. Peak. It's an honor to be here tonight. I'm looking forward to the discussion as well.
Me too. So let me begin with our first learning objective, which is to assess perinatal health and safety to reduce the risk of maternal morbidity and mortality in pregnant women of color. But first, let me ask the audience to give us your input on this question. In the United States, how has the maternal mortality rate changed in the last 3 decades? So we have 4 options. A, it's increased at a rate of 1.4. B, it's reduced at a rate of 1.5. C, increased by 2.4 times. And D, reduced by 2.5 times.
I'm curious to see what the audience is going to say.
Me too. Remember, there's increase, reduce, increase, reduce. All right, so a little bit more than half of the audience said that has increased by almost 2.5 times, by 2.4 times, 53%. And that is the correct answer. So we had a little bit of spread in the other 3 answers, but half of us are already with us. And so that means that we have a little bit of our work cut out for us tonight, but we've already got, at least half of the group already with us and ready to move ahead. So Dr. St. Louis, as we just illustrated in the audience question, there's a maternal health crisis in the United States that disproportionately affects women of color, particularly African-American, Native American, and Hispanic women. What can you tell us about this, and what are the primary causes of maternal mortality?
So unfortunately, as one of the industrialized or advanced countries, however we want to look at it, the United States leads the pack as far as maternal mortality. Twice the maternal mortality compared to France or Canada. Causes of maternal mortality, primarily in the United States, the majority of the maternal deaths occur in the postpartum period. And when we're thinking about causes, we're thinking about infection, hemorrhage, cardiovascular disease, particularly preeclampsia, eclampsia, will definitely seem to affect women of color, Hispanic women, and Native American predominantly.
So Dr. St. Louis, why do you think it is that compared to other high-income countries, compared to France, for example, the United States is seeing such differences? We normally would think about ourselves in comparison to maybe other countries that have differential wealth patterns or something. And so tell us why the United States do you think would be different than other developed nations or other high income countries?
Sure. Interestingly enough, there are a couple of reasons. Number one, in the United States, compared to some of those industrialized countries, we seem to have a lower rate of maternity care provider compared to the number of women who are pregnant.
Mm-hmm.
So not only do we not have enough, so number one, we don't have enough providers. Number two, the ratio of providers in our country is also different from that of other industrialized countries, except maybe for Canada. And the fact that most of these countries, the maternity care is primarily based and led by midwifery, so midwifery-centered care. So, for instance, in England, which seems to have one of the better models in terms of maternal mortality, New Zealand is another one. The primary provider for maternal care is led by midwives, and then the obstetrician are primarily hospital-based, and they take care of patients who are high risk, so that you have a wider variety of providers, including family medicine physicians who are providing care to low-risk women. And so how does that affect the outcome? One of the first things that you'll see is that there is a decrease in the rate of cesarean section or surgical deliveries. And so in a lot of these countries, there's a high rate of vaginal birth models. And also because they're midwifery-led models, there is also greater emphasis on the postnatal care, which is something that in the last couple of years, ACOG has made it part of its one of front and center missions, which is to change the way we approach postnatal care. And knowing that the majority of maternal deaths occur in a postpartum period, it goes to show that if you put an emphasis on postnatal care and how we provide postnatal care and plan with patients how they're going to follow up with us, then the outcome that we see, the outcome differences that we see in other industrialized countries compared to ours are a little bit better explained. And so, I think one of the things that we can do here when we're thinking about maternal care is to try to encourage a diversity of provider and increased number of provider, not just in terms of midwives versus OBGYN, but also diversity in what our providers look like, so that our patients can see themselves in their provider and establish a better relationship with their providers.
I think a lot of people would probably be surprised by what you just said, as far as here we're so fascinated and obsessed with having OBGYNs and really sort of leaning into C-sections as, even when they're not medically indicated. That's sort of a trend here in the United States, and finding that these are perhaps associated with worse outcomes. And do you think that you had mentioned that there's a lot of maternal mortality in the postnatal period as well? And do you think that having a broader social safety net for women in other countries in the postnatal period, so as far as maternity leave and paternity leave, and having those be accessible to all women, as opposed to women who happen to be working in jobs where it's, a luxury, as opposed to if you're, an hourly worker or something where that's not something that you can do.
Absolutely. And I'm glad you brought that up. That's, that's point number 3. And what are the things that differentiates us from other industrialized countries? The United States remains one of the countries that thus far has not been able, for some reason, able to embrace the idea of paid maternity or parental leave, right? Even some of the quote unquote less industrialized countries, when you're thinking about, say, for instance, maybe India, which traditionally has not been considered industrialized. I'm not quite sure why, but traditionally has not been considered that. They have paid parental leave, right? And so for us, when we think about the concept of maternity leave or paid maternity leave, paid parental leave, that also makes a difference when we're thinking about some of the issues in the postpartum period, postpartum depression, preeclampsia, and the ability of parents and new moms to be able to focus on their own health and the health of their newborn versus how quickly can I get back to work, or how fast do I need to be back at work. And that's something that we see a lot, especially in the hourly workers, where a lot of our patients and a lot of women in the community don't have the luxury to even really truly take time off from work after they deliver their infant, which then translate in their inability to follow up with their provider, especially if they have had surgery or if they have preeclampsia. If they're unable to follow up the way we want them to follow up, that makes it harder for them to be able to receive the care that they need. And so when you think about a broader social safety network, one of the things that I would encourage my colleagues to do is to then try to reach out to some of those community-based organizations that can partner with physician and provide some of that follow-up that a physician's office may not be able to provide, in order to increase the access and the outreach that we can do to support and elevate the women in our community who have just given birth.
Mm-hmm. So we know from your discussion that the rates for maternal morbidity and mortality are much higher for Black women, for Native American women, for Hispanic women, and that for Hispanic women in New York City, they're 3 times more likely to suffer from maternal mortality. And we know that from the data that 37% of this disparity is due to the delivery site for the hospital that these women go to for maternal care. Mm-hmm. So in this regard, let's discuss the interpersonal biases and racism and the structural issues, the structural racism that drives many of these underlying social and structural determinants of health that's responsible for maternal mortality. So why is it important, Dr. St. Louis, for us as providers to be aware of these factors? And why should our personal unconscious or implicit biases matter to us as healthcare professionals?
Absolutely. It's a great question. I think one of the reckoning over the past few years for those of us who are in obstetrics and gynecology is acknowledging the history, the presence and the role of racism in the history of obstetrics and gynecology, and thinking about the biases that we bring into the room when we're speaking to our patients. Something as quote unquote seemingly innocuous, the fact that there's this pervasive myth that people of color don't feel pain the same way than non-Hispanic white women. And so there is there are these pervasive racial biases that exist in medicine, and that have been perpetuated through medical education or lack of education, if you want to look at it that way. And so with bringing these personal biases, even if they're unconscious biases, the way we approach patients, the way we speak to patients, if we assume that a patient of color does not feel pain the same way, we're less likely to pay attention to the patient, or likelier to dismiss the patient when the person comes in with a complaint of pain. When you think about the lack of diversity in our healthcare force, that also affects the ability of the provider and the patient to connect. There are several studies, well-established studies, who have shown that having a Black male provider seems to increase the better outcomes for our Black male patients, and that also translates in women's health. And so the ability of a provider and a patient to relate to one another makes a big difference for the patient in terms of patient outcome, and the provider's ability to speak the patient's language, so to speak, to speak the community's language, if you want to look at it that way. And then when you also think about preventive, when you're thinking about adequate, being able to think about, or even think in a broader sense, if you're talking about nutrition to a patient, being able to understand that person's cultural history and what they normally eat. That would be that makes sense in terms of how you're going to counsel your patients. And so our biases in essence are sometimes drive the way that we speak to our patient, the way we approach a patient, the way we see a patient, and the way we counsel a patient. And so it's very important to not only be aware of our biases, but also always take stock of how we walk in a room and how we perceive our patients when we walk in that room.
Absolutely. Thank you so much for that. I want to talk a little bit about VBAC, vaginal birth after cesarean, because this scoring system has been controversial. It codifies structural and interpersonal racism and healthcare providers' unconscious biases. So can you talk a little bit about this measurement tool for birth and how it's contributed to disparities in maternal morbidity and mortality?
Absolutely. So the VBAC tool, for those in the audience who are not quite aware of that tool, is a tool that has been used by obstetrician gynecologists to counsel women who have had a previous cesarean section as they're approaching their second delivery. And so the tool was meant to be used as a way to counsel the patient in terms of their likelihood of successfully having a vaginal birth after cesarean section. The initial iteration of the tool took into account the race of the patient. And in 2017, I believe, a group of physicians and residents, surprisingly so, took a look at the tool and asked the question as to why race was a factor in that tool. Why should we pay attention to race in that tool? Mm-hmm. And that has led to the researchers who actually initially put the tool out there to go back and retool the tool, so to speak, and remove race as part of the components of the tool, because it was clear that race had no place in it. Number one, because the data that they looked at was retrospective data, which meant that the data in and of itself did not take into account the social determinants of health. And so the question is, was race in and of itself a factor, or was it the social determinants of those individuals who were in those data sets that then affected those individuals' ability to have a successful VBAC outcome? Mm-hmm. And so what I mean by that is that you will find that women of color traditionally tend to be less well educated or informed about their options for VBAC. And when they're informed of their options for VBAC, they're less likely offered the opportunity to have a VBAC. And so if you look at retrospective data and you're taking that into account, then the tool that was devised in the first place become loaded with bias, if you want to look at it that way. And so once they took out race out of that tool, they realized that the outcome themselves did not change so much, and other than it improved the outcomes for both patients of African descent as well as Hispanic patients. And so the VBAC calculator is just one example in medicine of many other clinical calculators that we use that take race as a construct. But when we started looking at these clinical calculators, we're not really sure why race would be a construct, since race is more of a social construct and not a genetic construct. And so the VBAC tool has been retooled. Does this mean that providers are going to be likelier to offer women of color an opportunity to VBAC in the right circumstances? We're not sure, but at least it's a step in the right direction.
I think we're in a moment of reckoning with the racialized medicine, where so many of our tools, the GFR for accounting for kidney function, spirometry, so many other things that we have had, these markers for structural racism, we're using race instead of racism. It's not our brown or black skin, it's the fact of how society reacts to that, and then what that does to our health. And so let's be more precise and figure out what we are trying to measure when we think about race. And so we're now having to go back, thankfully, and retool our tools. And this is just another example of that, so we can have a more accurate sense of how we can take a better care of African Americans as a population, of various marginalized populations, in a more effective way. So thank you for that.
Sure.
Before we move on to our first patient case, I want to ask another audience question, which is, what is the leading cause of maternal death among Black women? So we've been talking a lot about maternal mortality, but there are a lot of different reasons for that. So what's the leading cause of maternal death among Black women? So A, pulmonary and obstetric embolism. B, sepsis and infection. C, eclampsia and preeclampsia. Or D, postpartum cardiomyopathy. So I'll give the audience a few moments to think about that and answer. We're hoping that we at least get 50% right, since we got 53% right the last time. And so we have 56% who answered C, or number 3, and that is the right answer. So yes, we're holding steady, moving up a little bit. So eclampsia and preeclampsia is the leading cause of maternal death among Black women. And I know that you know a lot about this as an obstetrician, gynecologist, that these issues of maternal mortality affect women of all classes, that it's not just low-income women, that women who, are across the socioeconomic spectrum are affected by maternal morbidity and mortality. And I'll say that I had preeclampsia and was nearing eclampsia right at the time of childbirth. And, I am not a low-income person. And so these are issues that impact the entire Black community, women across the spectrum. So one of the best ways for us to illustrate the structural and interpersonal inequities in maternal care is to look at the needs of some individual patients. So Dr. St. Louis, please take us through the first patient case.
Absolutely. So in our first case, we have Miss Ada Faye. Miss Ada Faye is a 34-year-old woman of African descent. This is her third pregnancy. She has one child. Her medical history is significant for gestational diabetes. She is overweight with a BMI greater than 28. And she has a history of hypertension, which has not been quite fully diagnosed. So occasional hypertensions when she sees her primary care provider. She has been diagnosed with hypertension in the third trimester of pregnancy. In the past, she does have a history of a previous C-section, which result from a stillbirth, and then she had a vaginal delivery, which was a live birth in her only child thus far. And she is presenting now in her early stages of labor. She's currently on no medication, and she only reports taking her prenatal meds, which she takes publicly. And so I think one of the reasons that I was definitely attracted to this case when we were discussing this patient amongst ourselves was that this patient typifies the woman who would come in with a history of having had a vaginal birth and then having a C-section. And so now, how is this person being counseled? So in this case, her OB applied the VBAC score to decide whether or not this patient should have a C-section versus an attempted vaginal birth. And using the old VBAC scoring system, recommended that she had a C-section. And so the patient had a C-section. Prior to her C-section, she had an epidural placed. And after the epidural placed and the procedure was about to start, Mrs. Faye reported feeling severe pain and discomfort, which is quite common. And the anesthesiologist and the nurse anesthetist insisted that the epidural would work and told the OB to move forward. And then in terms of delivery complications, of course, anesthetic complication, the patient did feel a significant amount of pain during her procedure, in spite of the obstetrician multiple times letting the anesthesia team know that the epidural did not seem to be functioning to the best of its capacity. The patient also had some hemorrhage, and during and after the C-section, she had several elevations in her blood pressure that were quite. All right, so now we get to the postpartum period. Miss Faye ultimately went on to deliver a healthy baby, and she was sent home 2 days after her delivery, in spite of the fact that she had several blood pressures that were out of range and a red flag for her providing her care team. No, she was sent home, and it's important to know that she has a toddler at home. She is a full-time employee as a business manager with a limited maternity leave, and because of the job that she has, she's unable to avoid standing up for a long duration, and she also has to live not only at work but also at home. Complication postpartum, she had some issues with her C-section incision, which opened up and required increased follow-up. She was also unable to breastfeed her child, and she also developed DVT in her right calf.
So we know that about 65% of maternal deaths are due to preventable causes, and there are several clinical and social factors that increase the risk burden for Black women, Native American women, other women of color. So Dr. St. Louis, in the case of this patient, Mrs. Faye helps to illustrate some of these risks. What could have been done or should have been done to care for Mrs. Faye? And then we have some questions from the audience that are relevant in general and then specific to her case.
Absolutely. So I think one of the first things in describing this patient, we know that she was overweight with a BMI greater than 28. It would have been really good to help this patient, ideal to help this patient in terms of referring her to a nutritionist who was culturally aware, that would have been able to help the patient and making informed decisions about her diet to help her, if not lose weight, but specifically maintain her weight, so that throughout the pregnancy, her obesity would become less of a factor in terms of her risk factor for the pregnancy. In addition to that, I think, the blood pressures being elevated during a C-section and after the C-section were a red flag that definitely should have triggered the healthcare team to not only keep her a little bit longer, which is one of the recommendations that ACOG now has for patients who have increased blood pressure, which is for us to be a lot more vigilant about the different ways that preeclampsia and eclampsia can show up. And that would have triggered then the healthcare team to keep this patient a little bit longer, but also to set her up for closer follow-up, not just for her incision, but also for her blood pressure. Especially because she was diagnosed with gestational diabetes, having her work with a nutritionist would have also been really important for her in terms of her future health in the postpartum period and beyond, but also in terms of her health during the pregnancy, as well as how that affected her newborn. Given that she has a history of a previous stillbirth, which was not explained, that could have been related to gestational diabetes. It would have been good for her to have access to those resources so that she could make more informed decision and have a better care plan that she would put together with her provider. I think part of it is, when you're thinking about the case, especially you're thinking about what happened to her during a C-section, and the idea that it happens that providers tend to be a little less conscious of the fact that patients of color feel pain just like everyone else. And so sort of the dismissive attitude that, the epidural will start to work, that in and of itself can create a trauma for the patient. And later on, this patient is less likely to come back to the healthcare system. And this would not be someone that would be recommended for a home birth, or even and if she was going to use a midwife in the birthing center, she definitely needs to be seen closer to the physician. But having had that particular experience, this is somebody who is traumatized and less likely to come back in the healthcare system, when this is someone who would need a healthcare team, including a physician and a midwife, to take the best possible care of her. In addition to that, when you're thinking about nutrition, you definitely want her education and her nutritionist to be cognizant of her cultural history and her social history, so that the recommendations are recommendations that she is able to follow, that align with her values, align with her culture, and align with what she has access to. And when you're thinking about social determinants of health, it's very important to think about what does she have access to. The idea of food deserts and the idea that when you go to the same grocery store in different parts of town, that you're going to find different food items is something that we have to be cognizant of when we're taking care of our patients. When we're making recommendations to our patients, that's important as well.
Yes. Now, before we move on to the next two cases, I did want to make sure that we talked about VBAC and sort of because we had discussed that right before this patient case. And so can you talk about how that's relevant to this case in particular?
So in this particular case, I think that having the tool and using the way the provider used the tool, the provider specifically steered the patient towards having a repeat C-section, as opposed to using the tool as to open a conversation with the patient. The VBAC tool, even with the retooled VBAC tool, should not be used to drive a clinical decision. It should open a discussion with the patient and be able to counsel the patient and be able to give the patient the information they need so that they can make informed decisions with their providers, as opposed to the provider making a decision for that patient.
Excellent. You have already answered a few of the questions that came up in the chat. So I'm going to move on to our next case to make sure that we're conscious of time. Our next patient is Mrs. Rosario Lopez. Dr. St. Louis, can you tell us about this patient case and what's important for us to recognize with her?
Absolutely. So Ms. Lopez is a 26-year-old Latina woman, G1P0. This is her first pregnancy, coming in at 33 weeks, complaining of shortness of breath, who eventually was diagnosed with preeclampsia. Part of what we need is, what is important in this case, is that there was a delay in her diagnosis. She presented in the emergency room complaining of shortness of breath, and at that time was given an inhaler and discharge, and that the provider in the emergency room was not cognizant that her symptoms could be related to preeclampsia. Eventually, for this patient, she presented in labor. She had a prolonged labor, which was augmented with oxytocin. She had to be placed on magnesium sulfate because of the preeclampsia to protect her central nervous system. Eventually, she ended up having a cesarean section. Because she had a prolonged labor, she was on oxytocin. She was also on magnesium sulfate that increased her risk of postpartum hemorrhage. And in addition to that, we had issues with her in terms of controlling her blood pressure. She was discharged 3 days after her delivery and was told to follow up in order to manage her blood pressure. For this patient, she was admitted 4 days later to the neuro ICU because of eclamptic seizures.
So, Dr. St. Louis, how do clinician biases and medical myths impact care for women of color and contribute to maternal health disparities?
I think that when we think about biases and myths, sometimes we miss diagnoses in patients because the patient does not look like what we expect the patient to look like. So in this particular case, when Ms. Lopez presented in the emergency room, the providers who saw her, unfortunately, did not make the connection of her symptoms with preeclampsia because she didn't look like what a quote unquote a preeclamptic patient should look like. When you think about preeclampsia, you predominantly think of women of African descent. But we do know that Hispanic patients have a higher likelihood of actually developing preeclampsia compared to non-Hispanic white patient. And so preeclampsia, eclampsia, cardiovascular disease do not look like any one particular patient. And so providers should definitely have a greater, be more cognizant of when pregnant patients seem to show up and have specific symptoms and not be dismissive of those symptoms. And so I think in this particular situation, being cognizant that our biases can sometimes lead us to misdiagnose or miss our diagnosis in a patient is very important.
Mm-hmm. Mm-hmm.
And, I think part of what we also have to be cognizant of when we're thinking about maternal mortality and causes of maternal mortality, preeclampsia, eclampsia, definitely higher, 5 times higher in Black women, postpartum cardiomyopathy. When we're thinking about the whole spectrum of cardiovascular disease, definitely higher in women of African descent and Hispanic women. And a lot of the using the Ames bundle that have been developed in the past 10 years have been put to improve some of these outcomes. And so being able to standardize the care that we provide does go a long way towards removing the effect of our personal biases, both implicit and explicit biases.
Great. One of the questions from the audience was, should race be a factor in screening for hypertensive disorders and gestational diabetes in pregnant women? What are your thoughts about that? And then can you talk a little bit about why the rates of eclampsia and preeclampsia are higher in Black women and Hispanic women?
So the idea of race as a genetic marker, so far we have not been able to come to any one particular consensus. We do know that race is a social construct, and so when we're thinking about using race to screen, we have to ask ourselves a few questions, which is, is there a need for race correction based? Is that race correction based on evidence? And if we're going to use race as a screening tool, how are we using race? Is this self-reported? Is the patient reporting a certain way? But if the patient has several different race, a Black mom and a white father, or a Native American father and a Hispanic father, how does race then factor into that patient? Is that patient more Black? If one parent is Black, do we dismiss the other parent that's white? And so we have to be very careful when we're using race as a construct to screen patients. When we think about the preeminence of cardiovascular disease and conditions in African American women compared to white women, a lot of times we also have to ask ourselves, what role do social determinants of health play? And when we think about obesity and what type of food and diets and condition, stress that we know affect individuals of color in this country, and how that affects the person's health, that also has to be taken into account. And so, yes, there's a predominance of cardiovascular disease among Black women, but does this mean that we have to use race as a construct to screen? I think that's a little bit of an overreach, because we thus far, we cannot account for the impact of race, especially if it's something that the patient is self-reporting.
Mm-hmm. Mm-hmm. We've talked a lot about bias on the part of healthcare providers. And so one of the questions that came in was that, aside from sort of guideline care for equitable maternal care, are there any measurement tools that can help mitigate healthcare provider bias when assessing pregnant patients who are from racial and ethnic minority backgrounds?
Well, that's a evolving question. I think right now we are still grappling with the effect of biases and how to change not only medical education, but how to change the perspective of providers who are currently providing care. And so we are looking at a lot of healthcare systems who are now implementing implicit bias training in their system to increase awareness. We are also seeing a lot of initiatives that are looking at respectful maternity care, and so implementing respectful maternity care throughout healthcare system and involving physicians in those initiatives in order to change their interaction with patients. I think the Ames bundles have gone a long way towards standardizing care and decreasing the effect of bias and race in the care that women are able to access when it comes to preeclampsia, postpartum hemorrhage, and so on and so forth. But the jury's still out. We still have a lot of work to do.
Great. And then one person just wanted to clarify. She says, excellent presentation. Her question is, when we talk about the maternal health crisis, is this what we're talking about, the maternal care disparities crisis that we see in Black women? Is that what we mean by the maternal health crisis? And then are maternal disparities in other women of color also reaching what we would call a crisis level? And that question is also recently just came in.
That's a very interesting question. I think the slide that we had earlier when we were looking at maternal mortality rate, and we saw the rates, the disparity between Black women and women, other women in this country is quite significant. And so when we talk about the maternal health crisis, a lot of times the image that we're thinking is women of color, predominantly women of color, followed by Hispanic women and Native American women. The rates, though, seem to be significantly higher for Black women than other women of other races in this country.
Mm-hmm. So we've talked a lot about preeclampsia and eclampsia, some of the main causes of maternal mortality in Black women. What are some of the other cardiovascular conditions that lead to disproportionate maternal mortality and morbidity, and how can we mitigate this?
So definitely postpartum cardiomyopathy, obstetric embolism. So deep vein thrombosis seem to be two of the other big ones when we're thinking about cardiovascular disease in the postpartum period. In terms of mitigating, I think a lot of it is, number one, physician awareness and educating our providers, not just OBGYNs, but our primary care providers, our providers in the emergency room, so that sometimes when these patients come through, that these patients do not fall through the cracks and get misdiagnosed, but also educating patients so that patients are aware of the signs. Unfortunately, as you well know, even when patients are aware of the signs, sometimes providers don't listen. And so that's why a lot of the emphasis has to be on providers being able to hear when a patient says that something is wrong. Because at the end of the day, the patient is the expert on her own body. And if we can get providers to start thinking about it that way, that it's two experts, the patient and the physician working together, that goes a long way towards mitigating some of the near misses that we are having.
All righty, so let's move on to our next case. Dr. Swiftwater. Dr. St. Louis, can you tell us about Dr. Swiftwater and the risk of disparate maternal health care in older women? And I have to say that I was considered advanced maternal age when I was pregnant, and I was like, that's a thing. I didn't even know there was such a term. So she kind of reminds me of myself. Can you take us through her case?
Sure. Dr. Swiftwater is a 41-year-old Native American. She is, this is her fourth pregnancy. She has no children. She called her obstetrician when she was about 22 weeks because she did not feel well. And she was worried because she had 3 previous misses. And so this was her fourth attempt at having reaching a viable pregnancy. Her obstetrician felt that she was overreacting and was dismissive. And the patient then presented to the emergency room 5 weeks later in preterm labor. She had prematurely ruptured her membrane, and she also had a chorioamnionitis infection. The healthcare providers assumed that she had other children, and so the Dr. Swiftwater had to explain that this was going to be her first viable pregnancy. She had never reached viability previous to that. And even though she was a physician, one of her complaints was that she was not heard in the emergency room and in labor and delivery, that she was treated somewhat dismissively.
All right, let's ask our audience another question and see if we can at least keep our 50% going rate. The question is, maternal health inequities increase with maternal age. What is the mortality rate for Black and Native American women over the age of 30 years compared to white women? Is it A, 1.5 to 2 times, and it says 5, but it's supposed to be 1.5 to 2 times higher, B, 2 to 3 times higher, C, 3 to 4 times higher, or D, 4 to 5 times higher? So I'll give you a few minutes to answer, and keeping in mind that that first answer is 1.5 to 2 times higher. All right. So we've been going with C, and that is what the majority of people have chosen this time. But unfortunately, the answer this time is D, 4 to 5 times higher. And that is a significant magnitude of increased risk for women who are 30 years old. And 30 is not a significant, the older I get, the younger 30 sounds. It's not a significantly high advanced maternal age, to start seeing these market changes in racial disparities. But already at age 30, there's a 4 to 5 times higher risk of maternal mortality. And so that is significant. It takes my breath away. Very few of us, only 20% of us in the audience would have guessed that. What are your thoughts about the audience choices, Dr. St. Louis?
It's similar to what you said, and doing some of the research, looking at women who are quote unquote older, right? You see that the effect of weathering, which we're just now starting to be conscious of. And so the effect of stressors, daily stressors, racial stressors on the health and mortality of minority individuals, African American, Hispanic, Native American, and how that affects their well-being, their health and well-being, and their susceptibility to chronic illnesses. And so when you add chronic illness to pregnancy is going to exacerbate any underlying condition that somebody has. And so as you get older, those conditions, there's a greater likelihood of having a chronic medical illness. And so that is compounded by being pregnant. And so you can see that maternal mortality is definitely going to be increased as we age.
All right. Can you talk a little bit more about these inequities that increase with age?
Sure. So in the, when you're thinking about chronic medical illnesses, obesity and chronic hypertension and diabetes, as you get older, there's a greater likelihood of being affected, a greater risk of having these chronic illnesses. And so that was, I mentioned before, to be the great equalizer. It's going to exacerbate whatever is latent. And so with our older patients, we tend to have a greater risk of preeclampsia. We tend to have a greater risk of eclampsia, gestational diabetes, and all of these illnesses that then render these women higher risk and increase their mortality and morbidity in pregnancy and in the postpartum period.
So in many cases of disparate health and healthcare, the patient is often blamed for not being informed or for taking the onus to improve their health. Dr. St. Louis, what does the data show here? And tell us about maternal health care in terms of higher education.
That is the great paradox. I think when we started looking at the maternal health data some 10 to 20 years ago, as per that slide that we saw earlier, the maternal mortality reached a peak in 2011, 2012. And so when we started looking at the data, one of the first explanation that we were looking for was whether or not the maternal education, social construct whether this person was well educated, the type of job, their access to healthcare. Did any of those have any effect on their healthcare outcome? We now know that even when you compare Native American and African American women with some college education to their white counterparts, their healthcare outcome are still worse. And so when we're talking about maternal mortality and morbidity, the healthcare outcome for an African American woman who is college educated and has private insurance is on the same level par as a white woman with a high school education. And so our education does not seem to be a protective factor in this situation. And so when we look at all that, we are now finally coming to terms with the fact that biases and structural racism seems to be the factor that is driving the maternal mortality. That even when a woman, as as per some of the more famous moms in the press, Serena Williams and other women of color who are famous, who have come forward to discuss their personal experiences during their pregnancy and the postpartum period, these biases are driving maternal mortality in certain instances, and that the provider will not listen to that patient, which is what essentially happened in the case of Dr. Swiftwater, who called and said something is wrong, and yet was dismissed by her provider. And it's a very common story that I hear from women, on a weekly basis.
Yes. And I will say that has happened to me as a female physician as I navigate my way through the healthcare system, a female physician whose research is patient-provider communication and empowerment. And so I have all the tools available at my disposal. I have the social capital, the medical information, and yet I still face the challenges because when you're ill, you're not at your best game.
Mm-hmm.
When you're sick, you're tired. And when I had my twins, and I had several issues that came out during my hospitalization, and I tell people about it later, and they're like, "Did you report those people?" I was like, "I was so tired." I did not. Had I been healthy and well and who I am right now, absolutely. But when you're sick, you just want to get well,
Mm-hmm.
and so it's a lot to ask of patients when they're not at their strongest, and when they have social identities that are marginalized, to, rise above all of those factors, and still be able to, engage their healthcare providers in a way that they can get the best outcomes for themselves.
Absolutely. I don't think I could put it more eloquently. And if it's difficult for those of us who are well educated and do have the tools, imagine what it is like for that patient who may be 17 and doesn't have the tool, or that patient who may be 30 and doesn't have the educational background that someone like you or I has enabled for and so I think I agree with you that asking to the patient to advocate for themselves in those instances is an unfair thing, an undue burden to place on the patient. That burden should and needs to fall on the healthcare system and the providers to change the way that we approach our patients, and to truly approach our patients with respect, and seeing them as a human being, and really be able to listen to that person when that person is saying, my body is not functioning in the best way that I know that it can, because ultimately they are the expert, as I said before, in their bodies.
Can you talk about respectful maternal care?
Absolutely. That's something that I've been very passionate about, in terms of how we change our approach to how we take care of patients. As I said earlier, for us obstetrician gynecologists, we're sort of having a little bit of a reckoning of the role of racism in our profession and where we come from, and how it has remained pervasive, and how we walk into a room, speak to the patient, and examine the patient and assess our patients, and so on and so forth. And so the idea of respectful care is that when we're thinking about equitable preconceptional, prenatal, postpartum care, and women's health in general, that we be cognizant of our personal biases, both implicit and explicit biases, that we be cognizant of how we walk into the room, that we respect the patient as an expert in her own right of what is going on with her, that we be mindful of the folks who are in the room with her, her support system. Sometimes, as you said, she may not be able to speak. And so that person in the room is a voice and an advocate for the patient. So to listen to that person and not be dismissive or offended that that person steps into the room and starts asking questions. And then also, of course, the most important one, that we respect the patient when the patient does not agree with our treatment decision. That's a big one for us physicians, because we walk in there as expert and we expect our patients to, so to speak, do what we say, right? And so the idea that we are now having to think about how we relate to patient, and that this is a conversation and this is no longer an edict. It goes a long way for the patient, but it's a difficult one for us to change in how we are trained. And hopefully we can change how we're training future physicians, nurses, midwives, to start thinking about respectful maternity care as a central tenet of how we care for patients.
Absolutely. Thank you so much, Dr. Lewis. This has been fascinating. And it brings us to our takeaway goals that each of us can play in trying to help end maternal morbidity, mortality disparities in the United States. Our SMART goals today are: 1, to recognize and address structural racism and healthcare provider unconscious/implicit biases in maternal care. Number 2, to integrate maternal safety bundles and best practices such as the 4 R's you just described to reduce preventable maternal morbidity and mortality. It's a tongue twister. And number 3, to develop care plans that focus on respectful maternity care to mitigate disparities in maternal health outcomes. And last, to implement effective clinical interventions and follow-up by the entire care team to prevent and manage major causes of maternal morbidity and mortality. We've received a number of questions already. You can keep submitting your comments and questions by clicking on the Ask Question tab. And you can also still email us at questions@cmeoutfitters.com or tweet to @CMEOutfitters. Please join me here at CME Outfitters for our upcoming briefcases and activities with more action steps that you can take to help end disparities. In particular, 2 of our upcoming briefcases will examine diversity and inclusivity in 2 important areas: chronic pain and orthopedic care. We'll be adding new content every month, and we really want to hear from you, our audience, on what we need to do so we can have an impact on these very important issues. You can find out all about the upcoming live events and view previous ones on the DNI Hub here at the link that you see on your screen right now. Please remember to collect credit for this activity by using the Apply for Credit button on your screen. And again, thank you so much, Dr. Lewis, for your input today. It has been wonderful talking to you. Thank you for our audience for all of your work in providing equitable and holistic care to patients around the globe.
Thank you so much for having me. It was a pleasure talking to you today.
All right. Have a good night, everyone.